right, so this is our portion where we ask questions, either from the audience or our social media. And I want to thank you guys for hosting us here, and this has been very educational, very informative, and you know, we're just very honored to be here. So some of the questions that we have are, some of our general are very specific, and we kind of pick and choose. But we'll start off with you, Dr. Niederberger. There's a lot out there about infertility supplements and things that can help boost your fertility. But overall, what other health problems can put you at risk for infertility in the future? Is it like heart disease? Is it bad eating? Or how can men today avoid needing any infertility workup down the road?
It's a great question. First, thank you so much for stopping in Chicago. I mean, this is an amazing thing. This trip that you're taking all the way from Florida up into Canada, it's an amazing thing. And so thanks for stopping in the middle in Chicago and being with us. It's really wonderful to have you. A big part of the problem is we're beginning to understand that a lot of male fertility is genetic. It's kind of weird that you can inherit something that you can't pass on to your kids, right? But that's really where the data is beginning to point. So I think for most men, it's really important just to know that a healthy lifestyle, you know, getting exercise, you know, doing the things that are good for overall general health are extremely important. A good diet is extremely important because the cells that are inside of the testicles are really rapidly dividing. They consume a lot of energy. So the healthier that you are overall, the healthier your testicles will be. But a lot of guys think, oh, this is something that I did. You know, the reason why I can't conceive with my wife in my 30s is because I did something bad in my 20s. And that just is not true. It's really important. It's probably a hand that you were dealt when you were a little embryo floating in your mother's womb.
Another question we had was, how is obesity linked with erectile dysfunction?
Well, I would like also to thank you for coming here to Chicago, and thank you for this beautiful gift for the car that we're going to leave.
Hey, we do need drivers all the way to LA, so you can join us.
We'll replace with something else. We like this European name on your car. Tesla is a guy from my country.
Oh, is it? Elon is from your country?
Well, it's,
Tesla. Oh, sorry. Okay.
Continent. Nikola Tesla. So that's another great question. Obesity is the big epidemic that we are facing, especially in the Western world, especially in this side of the Atlantic Ocean, and it is correlated with erectile dysfunction, as it's correlated with any other major vascular disease. It's so correlated that it's predating the erectile dysfunction, any other major vascular accidents like stroke, like MIs. That's why we are sending these patients with ED. We are checking them for the risk factors and for to see if they have any risk factor to develop in the following years any major problem. So we should act on the obesity and prevent this, and work with our colleagues from primary care physicians, with everybody who is involved in this. Not only erectile dysfunction, also BPH is related with this. There are a lot of studies showing that there is a correlation between the high cholesterol and LUTS, so lower urinary tract symptoms. The one that I just mentioned before, the one that are triggering the consultation to a urologist. So lowering cholesterol, working on obesity, preventing diabetes is the way to do it.
So how do you guys suggest, this is great, we know all this stuff works, we know all these medications work, and we know there's really good treatment options out there. But what do you think it is about guys that just don't get them, you know, motivated to come see a physician? And we, through Orlando Health, actually did a study where we asked 1,000 men 2 simple questions. One question was, what is the make and model of your first car? Do you remember what yours was, Craig?
A Ford Pinto. Orange Ford
Pinto. How about you? Do you remember your first car?
My first car was actually a Fiat.
A Fiat?
Yeah. Which is, as I was taught when I moved from Italy to US, that stands for fix it again tomorrow. But we're doing a better job. Actually, the last advertisement for the Fiat 500 is involving one of the medications for ED.
Oh, really?
Where the pill of Viagra that this old gentleman in the central part of Italy is missing and falls into the reservoir in the tank of this Fiat 500 and gets bigger.
So we asked this question to 1,000 men, and we found 81% of men remembered the make and model of their first car, but only 50% remembered the second question, which was, when did they last see a doctor? So it goes to show that guys care more about their cars, more about technology, like these Apple Watches, and I think we're going to meet our activity level today, so we can have Chicago pizza after this. Awesome.
That's what we're standing so close.
But guys care more about their cars, so what do you guys do in your practice to get guys in and motivate them, not just to see a urologist, but to see ENT, to see their primary care physicians? Because we all know, and we're all on the same page, if everyone was healthy, you know, we would all just go chill out and drive the Tesla and not have to work. That would be awesome. I think that's what every physician wants, is for everyone in the world to be healthy. How are we going to get there? What do you guys think is going to be that hook to get more guys to come and see their physicians?
Well, from the fertility side, and I expect it'll be a little bit different from the erectile dysfunction side. From the fertility side, often we're seeing wives bring in their husbands, or the female partner bringing the male partner, because women are more tuned into their health care, and society generally thinks that if there's a problem conceiving, it's due to the woman. So I guess the recommendation that I would have to a guy is listen to your wife, or listen to your girlfriend, or listen to your female partner, because if they're trying to get you into the doctor, that's a really good thing. That's a sign that they are really behind you.
Well, it's interesting, in BPH we have exactly the same route. I remember so many wives coming with the husband in the office, say, you have to fix him because I cannot sleep. He's waking me up when he goes to the rush to the restroom. The ED, it's even easier, because when you have no erections, you don't think a lot. You just go there and you want to fix this.
Yeah.
And you try. I was actually surprised how many young, educated guys will go to the gas station, have these magic pills, trying there, and then say, this is not working, let me do something seriously for this.
Yeah. And the unfortunate thing is, if they're young like that, they probably have some cardiac disease, something else in there. And I know we always send them to a cardiologist for an evaluation, and that's just sad that that's the first presenting thing that they have.
Yeah, I think that's a great point, and this is what we are trying to do in a setting like a university. We are trying to play a global medicine. So if I see a patient with ED, I don't just insert the prosthesis. I try to evaluate why he developed this problem, and if I find something, I send this patient to the right, internist or endocrinologist or diabetologist. And as I said before, obesity is a great problem, and you have many patients that are going from my clinic straight to the surgeons that are dealing with obesity.
So what role do you think social media plays? So this whole event is very social media heavy. Last year we had over 350,000 impressions on social media over one day, and now we reached over 1 million already, and we're not even halfway done with our journey. And one story Dr. Karakol is going to share with you, it was, I don't know if you're on Periscope or not, but Periscope is live Twitter, and we had this really amazing, touching story that we had, and we would love to share it with you guys about the power of social media.
So, as you can tell, I'm the younger partner, and so I tend to be more tech savvy. But so Jamin is he really is a social media guru, and recently we started using Periscope, and Periscope is a live broadcasting kind of version of Twitter or Instagram, and when we're driving late in the evenings, there's a lot of free time, and the topics sometimes degenerate, and we tend to get onto Periscope and. Initially I told them, I doubted that there are many people listening. And over the last few days, we've been using Periscope quite a bit. And this one lady got on, she's been on there a few nights. And after a few days, she got on one night and just said, hey, I've been watching you guys. You guys are very entertaining, especially in the evening hours. And I managed to convince my husband to make an appointment to go in and see his doctor. But that's when it really hit me, it was more... I thought it was more of a toy or just, I hadn't really thought about its impact. But when you think about it, the reason we're driving and doing this whole thing is really to, if we can get one or two guys to take ownership and do a double take, and when they think about taking care of their car, they think first about taking care of their own body, that would be huge. And so the story gets even better. So we were driving through Ohio, And we asked her, where are you located? And she's like, well, I actually...
She came and said, you're driving by my office.
That's right. She was like, you're driving by our office because we charged in a charging station in Maumee, Ohio. And her office was 5 minutes away. So we decided to make a surprise visit, a little detour. We took all the camera crews and we went and visited her. Her boss wasn't too happy about it. But it was really unique and kind of shows you the power of social media. This is a lady that we're from Orlando. We connected with her in Toledo and had an impact on her husband's quality of care.
But not only her husband, she sent us an email today that they have 4 receptionists at that office, and all 4 of them got their husbands to make a doctor's appointment. So, I mean, we can pack up and go back home today. I mean, we've gotten our reward. But what's cool is using social media, using this car, using all this technology, we're able to engage an audience. This is not about us. This is not about any particular physician, any particular practice. It's about men's health overall. So that's our story. How do you see social media? I know some doctors are sometimes afraid of using it because of liability and everything, but how do you see it being the future of what we do in our practices?
Well, I participated in social media for many years now. I'm even younger than Sucho over there. So no, I think that it is a tool that engages people exactly as you describe. I think it's really important that people understand that when you see a doctor, you still need to see a doctor. A doctor needs to do a physical examination to really understand what your body is telling you and telling your doctor. But for awareness, for knowledge, for dissemination of information that will bring patients to the doctor, and after you've seen the doctor, for learning about what you were told in that short, often too short interaction, and social media is priceless.
Yeah. I agree. Social media are really great to educate generally. And this is a great combination with what we can do. We can reach as many people as we can with social media. We can go to the individuals. But if you want to do something on a larger scale, especially in the prevention work, social media are absolutely the way to go. And they're using it because when they come to our offices, they all know everything about us. They pre-screen us. And they know a lot of things about the diseases that they are affected by. So we have the job just to clarify some things and to help them in getting into this area.
Interesting, you mentioned UroLift. So my patient actually educated me about UroLift. I wasn't up to date on the trials out in Europe, and he actually brought it in and said, "Doctor, this is what I want." And then I contacted the company, and it was still a ways away from coming here. But we can use them as resources as well. On our Periscope feed, people will engage us and tell us about other nonprofits and send us different links to different articles. So we are all getting educated in the process as well. So it's not a one-way thing. I think it's a two-way thing.
I think this is a great example. So we are using social media not only to reach our patients, but also to communicate among the physicians.
Yes.
And this is a great thing that now I can really say that I've been practicing on both sides of the Atlantic Ocean. There's no big difference.
Yeah.
So we are cross-contaminating each other, and that's a huge advantage. I remember seeing the UroLift procedure 15 years ago in Australia.
50, wow.
By the guy who invented this, in Wollongong, a beautiful little spot onto the Pacific Ocean there. And now we are doing this here. That's a great thing because the knowledge has no border, and social media are helping this.
Well, on behalf of the entire Drive for Men's Health crew, I want to first thank our crew that's actually with us. There's 12 guys that are endlessly not sleeping at night driving. I want to, if you guys don't mind giving them a round of applause.
And we do have one more speaker. Unfortunately, he decided to show up late. No, I'm just kidding. but we're an inclusive group, so we're gonna definitely let him talk. So,
Save the best for last.
Absolutely.
Thank you for the car again.
No, don't. That's right. And Dr. Niederberg, if you wouldn't mind introducing our last speaker.
So African American men have about a 60% increased chance of getting prostate cancer and about 100% increased chance of dying of the disease. Family history is very important. So first-degree male relatives, fathers, uncles, brothers, sons with prostate cancer means that the man would have an increased risk as high as 2 to 4 times of having prostate cancer themselves. We probably mainly know that prostate cancer is the most common cancer in men in the United States. other than skin cancer, and it's the second cause of prostate cancer death in men in the United States. So how do we find prostate cancer? We use the PSA test. This is a blood test, and it's extremely important for men to realize what the test is. There's a lot of controversy about the PSA test, but the way I would summarize it is that, much like with that beautiful car, if you put somebody behind that car that doesn't know how to drive, they're not going to make it coast to coast, and they're not going to do a very good job. But if you put a race car driver or an expert driver behind that car, they're going to do a great job. So with this test, I think what some of the controversy is that you need to have somebody that's interpreting this test that knows what to do with the information. Now, what's really interesting about the PSA test is that this is what's happened to prostate cancer death in the United States since the advent of the PSA test. It's gone in half. In no other cancer have we seen this level of reduction in death. And I think it's largely attributed to the screening test, the PSA screening test. So at UIC, we've come up with our own guidelines about PSA testing that we think take into account some of the new information about the test. And the important things here are that we've considered when to start testing, when to stop testing, and how often to do it. So the important aspects from this are that we've now decided that men with risk factors that I mentioned before, such as African ancestry or a positive family history of prostate cancer, should begin testing at age 40. And men that do not have those risk factors, we usually start at age 50. And we actually decide the interval at which to test based on the value of the test. But the other important thing to know is that a PSA greater than 4 is considered abnormal and is oftentimes a hallmark of prostate cancer. Now, one of the issues with PSA is that it leads to a prostate biopsy, and we've had some difficulty in the past with accuracy of prostate biopsy. I like to use a needle in a haystack analogy, because with a prostate biopsy, a needle is passed into the prostate, but a very small amount of the prostate is actually sampled for tissue. And we know there's some error associated with that. We're trying to advance that, the technology, by using MRI to give us a better look. Sorry about that. Okay. To give us a better look at the prostate gland, to see if we can't target where biopsies are done to make them more accurate. We're at UIC are researching what's called diffusion imaging, and it's sort of a next generation of diffusion imaging. And I use this analogy here. If you drop the dye into a glass of water, you see that that dye moves over time and eventually mixes completely with the water. Well, water moves through our tissues in much the same way, and water moves through cancer differently than it moves through our normal prostate. So we're taking advantage of these physics with a next generation of diffusion imaging for the prostate that we think is going to be able to provide us accurate targets for prostate biopsy, and so that's what we're currently researching. The way we do that is here, as you can see here, is an example. This is a piece of the prostate that's been removed with robotic surgery. This is an image from the MRI, and then we compare that to how it looks under the microscope to try to perfect the technique. And we fuse the imaging together, the ultrasound and the MRI together, in order to aim the needle and the biopsy at the target. And the key is coming up with the good targets. So we're trying to innovate on the imaging side to know exactly where the bullseye, so to speak, would be in the prostate. So in summary, what patients should know is that they should know their risks for prostate cancer. They should be proactive in their health. They should understand their options and seek information about the disease and about the diagnostics and the treatment. And I think what we think a really good way to do that is to get them involved in research that can not only give them access to new technology and hopefully better technology, but also helps us understand the disease and helps other men. Thank you. Any questions?
One question we always get is about active surveillance and genetic testing, whether if you think there's any role for it. I think MRI biopsy is going to trump all that stuff that we do, because we're going to get a lot more focused biopsies. But even then, if we do have someone that's going to be in low risk category, even after we use all this technology, do you see a role for genetic testing? I think there's a few studies out there right now. How do you utilize that in your practice, and how do you see it changing our management as urologists?
That's a great question. I think there's, I think active surveillance and probably MRI have the real promise to rescue some of the problems that we've had with prostate cancer detection. So active surveillance and monitoring the low-grade indolent cancers that we think take 20 to 25 years to cause a problem, I think is a very important part of the treatment paradigm now. I use MRI to monitor men on active surveillance and hopefully reduce the number of biopsies they may need. Genetic testing is definitely exploding. Technology is getting a lot better. We're running a trial at UIC that we're about to open, actually testing how a genetic profile of the tumor affects treatment choice. We're about to start that trial here in the fall. It's sponsored by the Department of Defense. So that's using the Oncotype DX assay. There are several others available too. I think that show a lot of promise that may show us how that cancer may behave before it actually does, and may give us more confidence in reserving aggressive treatment for those men who show a signature of their tumor, sort of personalized signature, if you will, that shows that has potential to advance.
We've met a lot of men on the road that are like, you're recommending PSA tests, because we talk a lot about prostate cancer on our, because we have 10 days, so we end up talking a lot about the things that's near and dear to our hearts. And we get a lot of, on our Periscope or social media, they say, well, I thought the government said no PSA testing. Now, what is your recommendation, trumping what the U.S. Preventive Task Force has said?
It's a very interesting issue. We feel when we put together our guidelines for our institution, I brought together not only urology, I brought folks from our public health school, from our pathology research department, as well as our primary care. And I think it's really important that we have that dialogue with a variety of physicians and researchers that see this from different angles and give the literature a critical review. So, the Preventive Services Task Force did downgrade PSA testing, and I think it was based on 2 very large screening trials that showed conflicting results. The European trial showed a benefit in mortality from PSA screening. The U.S. trial did not. There are some issues with the U.S. trial, we feel, with contamination, PSA testing in men who were not supposed to get the test. And we think that influenced the results. However, we definitely took that information into account when we made our guidelines. I think some of the exciting things about PSA testing are with the early baseline concept. So we found in our data and also in others that an early baseline PSA in a man in their 40s that's less than 1 separates about 90% of the men who would ever die from prostate cancer. So what we think we can do with that information is maybe start a strategy where we do test earlier, but we don't test as often in men who seem to be in a safe zone. I think we get into some trouble with over-testing, repeat testing, and reacting to small changes in the number and acting on that. So we want to start early, test less often, and definitely we dismiss men from testing at age 70. Okay. So we don't do aggressive treatment on men that may just not benefit from it.
Thank you so much, sir. Thank you.
Top surgeons are on the road trying to change that.
And how are they doing it? They're going on a road trip.
Planning a cross-country road trip.
And they're doing it all from a super hot all-electric Tesla.
They'll be making several stops on the 6,000-mile trip, hosting
live webcasts and videos.